Good afternoon, and of course, good evening and good morning. I'm sure that we will have participants in this webinar from many sides and many countries. So I really wish you a warm welcome to all of you to this new edition of EPI-WIN webinar. Today, we are going to talk about COVID-19 and specifically on the COVID-19 variants. We have distinguished speakers and panelists. Dr. Sylvie Briand, Director of Epidemic and Pandemic Prevention Preparedness here from WHO, Dr. Maria van Kerkhove, Technical and Operational Lead for COVID-19 Response. We have Professor Dr. Anurag Agrawal, Director of CSIR, Institute of Genomics and Integrative Biology from India. And we have Dr. Lorenzo Subisssi, Technical Officer from here, WHO headquarters. Sadly, Professor Anne von Gottberg couldn't make it for this EPI-WIN webinar, but we are sure that we can count on her presence from some future EPI-WIN webinars. And with that, I'm giving the floor to Dr. Sylvie Briand. Over to you, Dr. Briand.
Thank you very much, Lubika, and good morning, good afternoon, and good evening to everyone. I want to start by expressing my condolences to those affected by the earthquake that hit Turkey and Syrian Arab Republic in the early hours of Monday morning. WHO and humanitarian partners are supported the affected population, and so far almost 8,000 people have died and many thousand more are injured, and we know that those numbers are climbing and will climb, and so that's why it's important that we all be there to support those people. But on the other note, it's a real pleasure to be with you again today. To talk about this very important subject about this virus that is causing the COVID-19 pandemic. The period in which we are currently is a very complex one because we are not in the same situation as when the virus emerged in 2020, but the virus is still with us. Some people say it's nothing. Why are you bothering us with this pandemic? We should be back to normal now. And others say, it's catastrophic. My neighbor died yesterday, and last month it was my great uncle who died. And who is right? Both perspectives are understandable because the risk of getting sick, the risk of having severe disease is variable. And depending where you live, and how old you are, if you have underlying conditions such as diabetes or cardiovascular disease. So each of us has a very different level of risk. So if you are a young and healthy adult of 30 years old, for instance, COVID-19 is not so much of a concern for you because you can get infected but not having a severe disease, or some of us, young ones, don't even get symptoms. But if you are more than 80 years of age and with underlying condition, for example, the risk of severe disease and being hospitalized, it's much higher. And the risk of dying also is very high because in this age group, the case fatality ratio is up to 50%. So the acute phase of the pandemic is ending, but this phase of transition is very complex and worth discussing it to understand the various legitimate perspectives on the situation, and also to continue to move together towards ending this crisis. When the SARS-CoV-2 virus emerged, we knew nothing about it, and we didn't know how it would evolve. And the initial outbreaks in the first affected countries were quite severe because nobody had immunity against this virus. Now, 3 years later, most of the population on the planet has immunity, either acquired through infection or through vaccination. And we know much more about this virus. This virus has evolved and we have adapted to it. We have had waves of different variants, alpha, beta, gamma, delta, Omicron. And since Omicron, the trend we have observed is that the virus becomes more transmissible, but less virulent, meaning that we have less severe cases. And we hope that this trend can continue like that. However, we know that the evolution of a virus is always unpredictable because there are a huge number of factors influencing this evolution, and we don't fully understand yet the dynamic of this. But what is important to remember is that we have the tool to manage the risk. And if you want to avoid transmission, the personal protective measures are still valid. Wash your hands, wear masks in crowded indoors, poorly ventilated places. And if you are at risk of severe disease, get vaccinated if possible. And today we want to talk about this virus, and we have invited distinguished speakers to share with you the knowledge on SARS-CoV-2. And those people have been living with this virus for 3 years, not in their body, of course, but in their mind, because we have thought about it, and they have monitored this virus for the past 3 years. And I think their knowledge is extremely valuable for us to better understand the situation in which we are currently, and to better look at the future to see how we will see what the situation will be in the coming months. So with this, I give you back the floor, Yubika. Thank you so much.
Thank you, Dr. Sylvie. Thank you. Yes, this is the situation we are, and exactly that's why we need to be vigilant, and we still need to stay informed of what's going on and what are the changes happening. And with no further ado, over to Dr. Maria van Kerkhove.
Thank you so much, Lubica. Thank you, Supriya, and thank you, Dr. Sylvie Brion. So I'm Maria van Kerkhove, also in the Department of Epidemic and Pandemic Prevention and Preparedness, and I'm our COVID-19 Health Operations and Technical Lead. I'm going to give a brief overview from a high level, and then I'm going to pass to Dr. Lorenzo Subisssi and Professor Anurag, who will give some very detailed overview of the variants, which is the topic of today. So next slide, please. I have 5 key messages that I want to convey to all of you, and these have been outlined by Dr. Sylvie Brion as well. So this virus is here to stay with us. What you see on this slide here is the epidemic curve since the beginning of the pandemic, with the latest peak illustrating the largest outbreak of Omicron that we saw, which moved across China in recent weeks. In fact, adding this data in terms of case reports had to rescale the actual epicurve that we were previously showing, dwarfing some of the previous waves of infection that we had seen previously. Now, the virus continues to circulate with us, and you will hear more about this in terms of virus evolution and the variants that we are tracking. But it remains critical for us to maintain surveillance to understand the intensity of circulation around the world, because we are still seeing, next slide, please, large numbers of deaths across the world. Since December 1st of last year, there have been more than 208,000 deaths reported to WHO. And we know this is a significant underestimate of the true level of burden from COVID-19. The epicurve that you see here is actually looking at deaths over time. And while on the one hand, my second point, we see a significant declining impact from COVID-19 because we have tools that can prevent severe disease, that can prevent deaths. These include early diagnostics and getting into the clinical care pathway, the use of antivirals early in the disease course, the use of other treatments when people develop severe disease, and critically, the role of vaccination that are saving people's lives over the last several years. Unfortunately, we are still seeing a large number of deaths. We have between 10 and 40,000 deaths that are reported to WHO each week. There is a delay in terms of the deaths that are reported to WHO because it takes time for people to go through their full disease course. So at present, cumulatively, we've had more than 6.8 million deaths reported to us, but we know that that number is likely 3 times higher due to COVID-19. not even considering the excess deaths due to the delays in essential medical services and cancer treatments and preventative care over the last 3 years. So the virus is still causing significant impact, although we are in a much better situation than we were 3 years ago because we have so many tools. Next slide, please. This is a slide that I want to illustrate that the response to COVID-19 is comprehensive. It covers many different aspects. All governments, communities, people around the world are working to support the ending of the emergency of COVID-19. We are still in a public health emergency of international concern, and we are still in a pandemic caused by this virus. We hope that we can end the emergency of COVID-19 and move towards more sustainable disease management of COVID-19 this year and into the future, because the virus is here to stay. But the critical aspects of the response are collaborative surveillance and ensuring that we understand virus circulation. We have strong lab systems that can assess each of these variants, and we have analysis that can be done regularly so that it can guide our response. We need to ensure that we continue to support community protection in terms of risk communication, infodemic management. Misinformation, disinformation is rampant these days, and it is undermining the safe and effective tools that exist that can prevent the impact of COVID-19 and prevent deaths. And there are so many other levels of community protection that the organization is working on with member states. We need to ensure better, more scalable, safe clinical care, ensuring that patients that show up at health systems for COVID-19 or for influenza or for RSV get the appropriate clinical care and get into that clinical care pathway to receive the right care at the right time for the right individual. This also includes management and treatment for post-COVID-19 condition. We need to ensure we have access to countermeasures. We continue to focus on research and development so that we not only have safe and effective vaccines that prevent severe disease and death, but we have vaccines that could perhaps affect infection and transmission. We have better therapeutics. We have better personal protective equipment that is developed for women because most of healthcare is provided by women, but we need to continue to ensure that we have research and development that continues for COVID and that we ensure access to those materials as they become available with a coordinated and strong supply chain. And of course, we need coordination. Next slide, please. My fourth point is that countries are in very different situations in terms of where they are in ending the emergency phase and transitioning to more sustained COVID-19 management. As the World Health Organization, we look at this as a global risk. And so until no one is at risk, everyone is at risk. But the virus is here to stay. And countries are in different situations because of various aspects of their previous and current strategies of dealing with COVID, their current epidemiology and the variants that are circulating, the population demographics and the risk factors for severe disease, population level immunity from past infection and or vaccination. And as Sylvie mentioned, we have high levels of population level immunity, but in the fourth year of this pandemic, we are seeing some waning immunity, certainly for preventing infection. So we are seeing reinfections, but we do see a strong, robust hybrid immune response for people who have had both vaccination and infection. And it really remains critical that we vaccinate 100% of at-risk populations and boost our at-risk populations in all countries. We need to continue to fight for access to life-saving tools. 30% of the world has not received a single dose of vaccine yet. And in every single country, key demographics are missed in terms of vaccine strategies and vaccine implementation. There are different capacities to implement in communities. We have operational readiness and a challenge and agility to adjust the response going forward. And public trust, societal engagement, and an unrest is really at an all-time low. And this is what we and many governments, many communities, faith-based leaders, youth leaders are working to increase. Next slide. And we have concurrent health crises that we're dealing with. COVID is not the only challenge that we are facing. We recognize this, but we have to deal with COVID in the context of everything else, health crises, non-health crises, earthquakes. And I sent my condolences as well to the people of Turkey and the Syrian Arab Republic for dealing with the earthquakes right now. And we have huge amounts of displacement, population movement, war, famine, drought, floods that we have to deal with COVID going forward. And my last slide. Just to say, I won't go in any detail with this, but WHO is working with all of our member states to end the emergency phase of the response, to really deal with the impact so that we live with COVID responsibly, integrate COVID into longer term respiratory disease management. And there are many aspects of this, but each country is in a different situation, and we're working with them as we get through this different phase of the pandemic into the longer term disease control. But the fight continues. There's a lot we can do. We are very hopeful. There's a lot that individuals that you can do listening online in terms of protecting yourself and your loved ones. Getting vaccinated remains critically important. Knowing what your risk is and lowering your risk in terms of utilizing masks and distancing and improving ventilation so that you can live your life. But we continue to work with all member states, and we will continue to do so until this emergency is ended. And we will work with member states as we achieve longer term COVID-19 disease management. Now I'll pass the floor to Lorenzo.
Thank you, Dr. Kerkhove. So my name is Lorenzo, and I am scientist in the Epidemic and Pandemic Preparedness and Prevention Department. I will give a brief overview of the process the WHO has to monitor variant and the overview of currently circulating variants. This slide is just to remind you that SARS-CoV-2 will continue to evolve as we will learn to live with the virus, and there are potential drivers of emergence of genetically divergent SARS-CoV-2 variants, and those are mainly uncontrolled transmission and prolonged human-to-human transmission in areas where there is limited surveillance and sequencing, and so we have limited capacity to follow the virus evolution. Another one is viral adaptation following prolonged circulation in susceptible animals, and we know by now that there are a lot of susceptible animals that SARS-CoV-2 can infect. Of course, recombination of SARS-CoV-2 with other coronaviruses in animal and humans, this is something that we cannot exclude, though it's a bit less likely than the other ones, but we need to follow virus evolution in order to make sure that this is not happening. And then the main driver is the persistent SARS-CoV-2 infection in immunocompromised, whether they are under treatment or not. So I think in terms of the process that we follow, there are two steps. One is looking at any variant that shows early signal of growth advantage over other circulating variants and significant spread, and this is a sensitive step where we follow up and track those variants more closely. An example of these are all the Omicron subvariants that we monitor. And the step two is when the growth advantage is suspected to be able to lead to a global predominance of that variant. Then a rapid risk assessment is initiated. And of course, this step is a bit more specific than the first one and requires also advice from experts of our technical advisory group on the virus evolution. And the second step will be covered later by Professor Anurag in his slides. This is just an example that we have of an early signal of growth advantage. So what we do is there are a lot of models to look at growth advantage, and they all have their strengths and weaknesses, and it's important that more than one model is used. So we have some models in-house as well as models that scientists share with us to look at that, and we look at global level, at regional level, and at country level to see if there are major changes in the trends of variants. And for example, here you see on the right hand side a growth advantage by week in Oceania, and you see that for example, these newly labeled Omicron subvariant under monitoring XBF is showing some growth advantage in this region. It's important to say that there is a lot of variability across the various regions, so it's important to not just look at the global picture, but really look at the country and regional pictures. So in terms of circulating variants globally, we have in the last month, as of 6th of February, almost 100,000 sequences have been shared through publicly accessible database like GISAID. And just this is important to stress that 99.6% of these sequences are Omicron. So we are really dealing with a scenario where Omicron is the vast majority of the sequence that we track, that we look at. And the BA5 prevalence is now at around 50%, declining from 70%. I'm talking about BA5 and sublineages. Of course, there are many sublineages. For BA2 and its sublineages, we have a stable trend with around 10% of the global share. And then we have an increase in the recombinants, mainly due to the main variant that we are tracking now, the XBB.1.5 that Anurag Professor Agrawal will talk about. But there are other recombinants that are circulating, like XBF and XAY. And this is the list of the variants, subvariants that we monitored within the Omicron family. And as you can see here in this table, we have two columns for the growth advantage, just to stress that the importance of looking at different models. And this list contains the variants that are showing growth advantage in more than one model. But again, this is very flexible because it can change from week to week, and it really relies a lot on how timely and how much countries share their sequences. So in summary, BA5 and its descendant lineages are still the dominating variants circulating globally, with a prevalence of still over 50%. But there is a huge heterogeneity in dominant variant across region, with many subvariants being dominant in some regions and other subvariants being dominant in other regions. And I'd like to stress the message that Dr. Van Kerkhove and Dr. Briand have also mentioned. The virus has not stabilized into predictable pattern of evolution, and there are more variants that are expected, and they will have increased growth advantage and immune escape. And there is no really certainty on the change of severity, whether this is going to be increasingly milder. We hope so, but we could also have potentially a more severe variant. So this we don't know. It's not predictable. And there is a circulation of some recombinant that have been detected throughout the pandemic, current attentional XBB.1.5, but there are other recombinant that are circulating at lower level. And as Dr. Van Kerkhove mentioned, with waning immunity, really breakthrough and reinfection will occur. So we have tools, and they work very nicely. Vaccination plus infection protects very well against severe disease, but of course we'll see infections as variants pop up with some additional immune escape. And so it's important to stress the declining and unrepresentative surveillance and sequencing is of course making it more difficult to rapidly assess known and unknown variants and recombinants. And I think the last point I would like to make is that smart, which means representative surveillance and sequencing, remains really the critical at this stage of the pandemic. So with that, I'd like to give the floor to Professor Agrawal. Thank you.
Thank you very much, Lorenzo. So I'm going to speak from where Lorenzo ended. There is a very important need for smart surveillance and sequencing. And obviously, after surveillance, you also need smart risk assessment. Because as Lorenzo said, it is far from clear that future variants will necessarily be mild. There could certainly be a possibility where a future variant becomes more severe. Next slide. There's a busy slide. I don't actually expect you to go through it. All I want to point out to you is that compared to Alpha Delta, shown in the top, the other Omicrons, almost all of them, are very similar to each other. And no matter which parameter that you use, it's very obvious that they look very much like each other. And all of them share a few very critical things, which is that change the receptor binding, but they have massively changed their ability to escape antibodies. Next slide. A question that keeps coming is, why we have stopped at Omicron and further names do not keep coming from us. It depends a lot on point of view. On the bottom slide, which looks at emergence of mutations time-wise, the orange and to deep orange is all Omicron. People who are looking at it from that angle can see that Omicron has spread very widely in terms of the range of mutations. But the figure on the top is another way of thinking about things, the similarity between each other. And fundamentally, what you can see is that Omicrons are very different, yet very similar. Despite the very wide spectrum of mutations that we give numbers to in the Pango lineage system, they are far more similar to each other than to pre-Omicron lineages. And even when you look at their behavior in terms of clinical risk, public health risk, that we as a risk assessment group have to look at, they're all similar in the fact they have high immune escape. Each of them, you see development of immunity after a wave passes, then a new one coming out that escapes immunity. But fundamental feature of very high immune escape, ability to break vaccines, ability to cause reinfections, is fundamental to all Omicrons so far. Then, all of them have seen greater tropism. Tropism means a tendency to infect the upper airway compared to lower airway. So pneumonia has become less common with Omicron than it used to be before. And especially given the high level of immunity around the world, the severity, especially in people either previously infected or vaccinated, has been much lower. I would put a caveat here, as we have seen in multiple countries, where immunity was low, Omicron can cause severe disease, so it is not nature's vaccine. Another important thing that we have not yet factored into risk assessment are the long-term consequences of infection. So even things that appear mild in terms of acute infection could have consequences down the line, but we have less data on that. Next slide. So rapid risk assessment of variants basically looks at three very different things. One is growth advantage. We can estimate growth advantage quite a bit from sequencing alone. As the lineages get their names, the mutations, we can see which one is growing. Growth advantage can be either because of fundamental changes to transmissibility or because of greater immune escape. And immune escape is the other indicator that we look at, and lab tests have been pretty good at giving us an idea about ability of antibodies to create neutralization of these new variants. And also we can look at clinical indicators, EPI indicators, such as reinfections and others. The third indicator, clinical severity, which I guess for many people is the most important one because it brings to mind images of severe disease, ICUs, is the hardest to estimate because severity can never be understood outside the context of the host. So if we as populations have greater immunity, even a variant that is as severe or more severe perhaps than say Delta might appear less severe right now. But we take a variety of evidences. We take lab evidences, we take EPI evidences, and we put them together. And we provide a confidence assessment of low, moderate, or high. We try to complete our first assessment within the first month. And we try to create a comprehensive assessment that often depends upon lab studies that cannot be done very fast over the next 2 months. And I'll not go into too much detail about everything written on this slide. Simply, we can go to the next one, Lorenzo. I'll walk you through how we assessed XBB.1.5. Lots of pet names have started coming, as you see on popular media. But you can see that we released our first assessment on 11 January 2023, the subsequent assessment on 23rd January. In growth advantage, we could see in parts of America, particularly the Northeast, it was starting to rise. It was from a single region in the beginning. Later on, it became two. Later on, the signal became consistent across. And we were able to provide initially low, later on moderate confidence in our assessment. Antibody escape, which is immune escape in this particular context, was quite predictable based on even in silico assessment. We knew the mutation at the 486 site, and we knew that mutation is a particularly important one for escaping antibodies and yet maintaining receptor binding. So even from the sequence, we had anticipated antibody escape, and later on, as lab data came, our confidence in that again went from low to moderate. Severity, like I said, is most complicated to ascertain, even despite initial data where people compare fraction of people hospitalized with, say BQ.1 versus XBB.1.5, and the numbers are similar. There's so many other factors that go into severity that only with more data from more places, more detailed adjustments, will be able to know, we'll say with clarity, what our confidence is. As of now, we do not see any increase in severity with XBB.1.5, but our confidence in that assessment continues to be built. So therefore, our overall risk assessment was that we thought that XBB.1.5 would contribute to increase in cases globally. Like I told you, that is not a small thing. We don't know the long-term consequences. However, we were reasonably certain that we would not see any more severe outbreaks compared to other Omicron lineages. It would depend more upon the usual population immunity, the usual demographics, the other factors that Maria and others have talked about. Thank you very much. So we did not see there was any additional public health risk relative to other Omicron that were already circulating. Thank you.
Thank you, Professor Anurag. Sorry, are we having a little... Lorenzo.
Yeah.
I think it's... Yeah, I'm done. I hope now it's good.
I'm
sorry. No.
We
are having a little bit...
Yeah.
Mine it's... Okay, is this better now? Sorry about that. Sorry about that. Well, thank you so much, everyone, all our panelists, and I mean speakers, because we are going to open a little bit for the questions. And actually, we had some questions already for our distinguished speakers, but I would probably like to give the chance for all the questions that we got. So let's try to answer as many questions as we can. And there was obviously the question, and it's repeating through the chat, about how this change in variants and how this change in definitely in COVID variants will affect the vaccination, will affect, and where does WHO stand in sense of annual recommendation? Is this going to change the composition of the vaccine? Is this going to be, again, probably recommended to be as something like a flu vaccine going forward? Where do we stand, and what does this really mean in practice? So I'm opening the floor to whoever would like to start. Dr. Sylvie? Floor over to you. Thank you.
Yeah, thanks a lot for this question. And I think it's really important because when this pandemic started, we didn't know about the virus, so we didn't know if the virus will evolve or not, and how fast it will evolve. And we didn't even know about the seasonality of this virus, because at the beginning, it was affecting everybody because of the lack of immunity. So 3 years down the line, we know a little bit more of what is happening, although we don't have a clear sense of seasonality yet. But what we have seen is that in temperate countries where it's winter, maybe because people tend to stay more inside, and then there is an increase in transmission also of the virus. So we have a little bit more, a better understanding of the dynamic of those transmission. And what is very important now with this evolution of virus is really assess what is the impact of the virus on the countermeasures we have. So Anurag talked a lot about the virus and also the severity and the virulence of the virus. And so this is one very, very important point. But also we need to see how much the virus impact the vaccine effectiveness, the therapeutics, and also the diagnostics. So on the vaccine in particular, we have set up expert groups to look at the changes of the virus, how it impacts the vaccine effectiveness, so that we can see if it's necessary to change the vaccine composition. The initial vaccine was containing the ancestral strain that emerged in Wuhan in 2020. And this is the vaccine most of us have received for those who have been vaccinated. But as the virus changed, we have checked if it wouldn't be interesting to either change the composition, if it's a monovalent vaccine, or have bivalent vaccine with a different strain or different variant, so that we can expand the breadth of immunity and help people to develop antibodies against different strain of the virus. So the TAC-COVAC, which is a group looking more specifically at the composition of vaccine, has issued few statements and is guiding also manufacturers on which kind of vaccine would be required, and how can we collectively look at the information we have so that we can define what is the best vaccine, the best product we can have for the world. The difficulties or the challenges we are facing currently is really in getting good information in the timely manner. Because if we want to issue recommendation on vaccine composition, we have to issue them sufficiently in advance so that all manufacturers can adapt their production. And this timely approach is very complicated. It's complicated for flu, because usually for flu, we make this recommendation 6 months in advance of the flu season. And for COVID-19, we will need to make it in advance of some kind of seasonality of COVID that is to be also better defined. And so the timing is very important and will depend also on the vaccine platform, because as some of you may know, the mRNA vaccine can be produced much faster than other platforms. So we'll need to also align all those requirements with manufacturers and regulators, because they need also to look at the data that are produced by vaccine manufacturer to decide if the vaccine will be retained in the national vaccination strategy.
Thank you very much, Dr. Sylvie. Maybe the next question is, and I'm trying to scroll down, sorry, there are so many questions, and we really thank you for this participation, is how this change in variants as well will affect maybe the protocols in healthcare facilities and the treatments. Does that have any influence? How much do we need to change or adapt, and in sense of treatments of the patients? So maybe over to Maria.
Yeah, maybe I can start with this one. So as we've outlined, there is a process in place that we have to assess the known variants and detect new ones. So it starts with surveillance, making sure that we have good surveillance around the world to be able to track what is circulating and to detect new ones. We have the Technical Advisory Group for Virus Evolution that looks at the different mutations, look at the different variants, and assesses these, as Anurag and Lorenzo pointed out, for transmissibility, severity, and the impact of our interventions. That also includes therapeutics. It includes diagnostics. Do our diagnostics still work? Can we still detect patients? But also our therapeutics. So far, we have a number of therapeutics that we recommend for COVID-19, stretching from antivirals. We have monoclonal antibodies, we have corticosteroids, and we have other treatments that are catered towards more severe disease. Our therapeutics are holding up very well, particularly the antivirals and some of the more the therapeutics for the severe disease. The monoclonal antibodies are a little bit different there. But this is one of the things that we are constantly looking at, and we need data to be able to evaluate this, as Sylvie has pointed out, as Lorenzo has pointed out, as Anurag has pointed out, as I have tried to point out, because we need to be doing these regular assessments to guide the response as we go forward. We've issued clinical management guidelines and therapeutic guidelines. These are called living guidelines because we update each of the chapters as more data becomes available. That will continue because, as I was trying to highlight, we want to ensure that the clinical care pathway for COVID remains robust and strong as we look into the future of that. But this is something we have to assess as we go forward. We're in the 4th year of this pandemic. We know a lot more than we did in the beginning, but we still don't know everything. We remain humble to this, and science and scientific collaboration remains critically important. Right now, there are more than 600 sublineages of Omicron that are in circulation. All of these are quite similar in terms of their characteristics, as has been pointed out through the slides, but we still have to ask these questions with each of these viruses that are being detected. And we need to pay close attention to the ones that have this higher growth advantage, that tend to circulate and replace the other Omicron sublineages that are in circulation. But this is a constant assessment. And I should take a moment to thank all of our clinical partners, all of our expert networks that are out there that are constantly working with us on this. And we need to emphasize that the research and the studies need to continue in patient populations so that we can make sure that our assessments are reliable, are robust, and are rapid, so that any changes that need to be made going forward, we could do very quickly, and we can update our guidance. And that includes guidance for therapeutics and clinical management.
Thank you, Maria, for responding this question. So maybe we can go again. I'm trying to put like a couple of questions together so we can get. So maybe there were a couple of questions, and this also got on our EPI-WIN email about the T-cell immunity protection against COVID-19 and will the possibility of new vaccines for COVID-19 use the T-cells or memory cells? Not sure if Lorenzo or Dr. Anurag would like to respond to this. Or both, yes.
So I can start, and then Anurag, you can complement. I think the T-cell immunity is associated with the protection against a severe disease, and we have not seen a decrease in the vaccine effectiveness when it comes to protection against severe disease. So, of course, T-cell immunity is really a key component of the immune response, and of course, any effort to improve current vaccines are welcome. But just to reiterate that those are working really well in protecting the populations that are vaccinated against severe disease.
I have nothing to add to that. I think that's very well said.
We can't hear you.
Oh yeah,
Sorry. Yeah.
There you go. Okay.
Didn't press the button. Thank you. So let me go. So a question was about the new data on the real effectiveness of the bivalent vaccines. Seems to be protective against the new variants. What can we expect, or tell us about something new that might be considered beyond the current bivalent vaccine? Is there any thinking about, possibilities of different components, of different ways of producing the vaccines for the future? There are a couple of questions related to that. So again, whoever would like to, Dr. Sylvie, Maria, Dr. Sylvie, okay, please go ahead.
Yes, thank you very much indeed. This vaccine field is in constant evolution. There are many different vaccine platforms, and also trying to look at other ways of administering vaccine. You may have heard of mucosal vaccine as well, trying to stimulate immunity in the upper respiratory tract. And have a different way of administrating the vaccine to stimulate different parts of the immunity in the body. But also, I think researchers, what they would like to have is pan-SARS-CoV-2 pan-sarbecovirus vaccine, which means a vaccine that could work in any circumstances, whatever variant is circulating, and have really stimulate a broad spectrum immunity so that people can face any kind of variant. So this is research. We are not yet there, but they are good progress. And if this works, I think it will be very important for other viruses like flu, for instance, where we are also looking for a universal vaccine, so that we don't need necessarily to repeat vaccination every year, but we can have maybe longer term immunity, at least for flu, because then people can have defenses against circulating influenza viruses that can last much longer. So these are the avenues we are exploring, and researchers are very active on this, trying to find ways forward. In the meantime, in absence of those pan-sarbeco virus vaccines, we are trying just to maybe play a little bit with not only the composition, having bivalent, or we can even have multivalent vaccines, or also the administration of booster, and the way we can then stimulate the immunity for different type of variants. Thank you.
So Lubika, if I could just add
yeah,
something
yes.
to Sylvie's great answer.
Of course, please go ahead.
Just to highlight, as Sylvie has pointed out, this is an active field and there's a lot of research in this area. I think, people are asking us a lot of the time saying, I don't quite understand. I've already been vaccinated and, I've received 2 doses or I've received 3 doses. So why are you telling me that I need more? And I think what is really challenging right now, and this is certainly a communication challenge as well as we go forward, this virus is here with us to stay. And we are seeing a really robust immune response, and certainly a hybrid immune response from people who have been both infected and vaccinated. Most of the world did not receive vaccine very early on in this pandemic, and many people have been infected and reinfected. We've just recently done an analysis with this global collaboration around the world, illustrating the critical importance to get vaccinated even if you have been infected, because that vaccine provides that additional boost to your immunity to protect you from severe disease going forward. There's a lot of uncertainty as we go forward in terms of how often people may need a vaccine or may need a boost. But with this virus here with us to stay, we do know that people who are in the at-risk categories, at risk for severe disease, over 60, immunocompromised, are frontline workers. We have recommendations out that recommend those people in those categories to receive an additional boost 4 to 6 months after their last one. And that remains critically important in terms of whichever vaccines are in country, vaccines that were developed by the ancestral strain, vaccines that have Omicron within that in themselves. These are really effective vaccines at preventing severe disease and death. So it's not only important if you've been vaccinated, if you've been boosted, but when were you boosted? And if you're in an at-risk group, look at your national guidelines, look at the local guidelines around you, and look at when you need that next dose. We can't say for certainty how often people may need doses, but it will vary. It will vary by how old you are and what at-risk group you are in or not. But there's an incredible group of people around the world that are working together on that. And Sylvie outlined the technical advisory group for vaccine composition that is analyzing data and needs better data to analyze, looking at the compositions of vaccines going forward. We've mentioned the TAG-VE. There's a lot of people that are around the world that are working together to make recommendations for the globe, not just for high-income countries or for some countries or people who will have access, but for everyone who's out there. And that's our responsibility as the World Health Organization, to help everyone everywhere. So vaccines are part of that strategy going forward, not just vaccines though, vaccines and not vaccines only, because there's a lot of other tools that we have, diagnostics and therapeutics, clinical care, masking, improving ventilation, really knowing what your risk is. All of that remains important. Live your lives, but live your lives as responsibly and as carefully as you can, using the tools that you have access to. Thanks.
Yes, and I would like to add something, maybe it's not very clear. Maria mentioned that some people have been vaccinated and they are getting reinfected, for instance. I think it's very important to understand that the vaccine will trigger an immune response. But some people have a very weak immune system, like elderly. And so even if the vaccine is very good, the response of elderly people may be very weak just because their immune system is not so strong. So in addition to this immunity waning over time, and we still don't really know how long it takes for the immunity to wane, but for certain people with a very weak immune system, of course, it's better to regularly stimulate this immune response because we know that it's weak in any case, and so we need to help them to mount a much stronger response. So I think these are things that are important to understand. Otherwise, people may think that, okay, elderly people, they are still dying even if they are vaccinated. But I think it's just because the vaccine is given to people already with a very weak immune system. So the vaccine does its best, but it's not sufficient necessarily. And that's why other measures like washing hand, mask, and other protective measure, and also treatment, early treatment in those people with a weak immune system might be really a good complementary tool to reduce severe disease and mortality.
Thank you, Dr. Sylvie. And I would like to ask Dr. Anurag and Dr. Lorenzo maybe a little bit more what this means for the future. I mean, tracking and surveillance and variants and the change and everything. Can you hear me? Sorry?
Yeah.
Yeah?
Yes, we can.
No, sorry, I was distracted. So how do we continue? Do we continue doing the same surveillance, the process of, I mean, tracking the variants, the genomic surveillance? What is for the future? And how will this impact testing as well? Because we know that the testing is declining, and this is why we maybe are not on the same level as before, and we are not tracking so actively the virus, or we are. So where exactly where do we stand for the future, and what do we expect? And maybe another question is, are we going to see more of this recombination of the variants? Is that also something that we are going to see in the future? So yeah, over to you, whoever wants to respond first.
I'll take a stab at it.
Yeah.
I mean, the first thing that we must emphasize is that before we have sequencing, before we have surveillance, we have to have testing. If there is no testing, there is no positive sample to be sequenced and therefore for surveillance. The second part is surveillance is not just about testing and sequencing, it is also about sharing data in a timely manner. And without data, you cannot actually do surveillance or risk assessments because it's not just about the sequence, even if you get it. It's about all the other data that goes into risk assessments. And as I think Maria said very clearly, then Lorenzo also emphasized, we are suffering to some degree from paucity of data. And going forward, if things don't change at all, surveillance will get harder. And let me illustrate why. The biggest threat, if we were to imagine worst case scenarios, although everything is possible, recombinations, severe mutations in humans, everything is possible, it is less likely that Omicron suddenly mutates in a human being to create the next lineage that is extremely virulent. The worst case scenario would be of Omicron or whatever is circulating, jumping to an animal, mutating further in a way that's not very harmful to the animal, but becomes more virulent to the human being, and then jumping back. So when we look to the future, we have to ask ourselves, hey, are we doing a good job of surveilling the evolution of the virus in humans' infections? And if the answer has a component that says we are not testing, then clearly the answer is no. The large parts of the world where no testing is occurring clearly can be fertile grounds for a new variant to come that is in the unknown category, right? We don't see it, we don't hear about it, we will not know it until it comes to a country that is doing both testing and sequencing and sharing. The second part is, are we doing anything about surveillance of habitats, wild animals jumping to and fro? We haven't even got to that part fully yet. So I would say to prepare ourselves to ensure that these kinds of worst case scenarios do not occur, we need to do much more than we are doing today. But given the available data, I would say we are doing a fair job of addressing the typical variants that catch public attention. And, they get all kinds of names, but we try to give out a reasonable risk assessment for them. I don't think we will see a fundamental change between the various Omicron lineages until something fundamental occurs about the severity, the tropism, and things like that. I'm going to stop here, see if Lorenzo wants to add something to this.
No, I don't have anything to add.
Thank you. Thank you very much. And as we are close to an hour of this very interesting webinar, and I know that our speakers can see that there are many questions. And even though we tried, to respond and through your presentations, thank you very much on group of questions together. Let me ask you the final question for this webinar, and that's what's next for COVID-19 and this pandemic. So if you can just, because that was one of that's the part of the title of this webinar. So it would be really nice, not only on the variant side and, the perspective. So what's next, maybe for the next couple of months, maybe until the end of the year? I'm not asking about the predictions, correct? That's not the question, but how do you see where are we heading and what is actually that we can expect maybe. But over to Dr. Sylvie Briand and then Maria and then Lorenzo and Dr. Anurag, if we can do that order, please. Thank you.
Thanks a lot, Lubika. I think regarding the virus, and I hope Lorenzo will be in agreement with me, but we cannot predict. I mean, viruses evolve, and it's nature, and we cannot predict. Of course, what we hope is that the trend that we see currently will continue, and we will have still a virus that is transmissible but less virulent, and so we will be able to manage really the negative consequences of this virus more easily. Regarding on how we can address the coming months, I think what is very important is that the virus is still circulating. So we are still, in a sense, in a pandemic situation because the risk is global. And so it's very important that we manage the end of the acute period of this pandemic together. A lot of collaboration between countries is still needed. It's not each country doing its own decision making and implementing those measures. Of course, each country has the sovereignty to make their own decision, but it's very important that we continue to collaborate and try to have a global perspective on this, because the virus doesn't respect border. And so we need, as human being as humanity, a collective humanity, also to remain together in solidarity and make sure that we continue to build on the things that have worked well during this pandemic. So the next thing that is also very important, in addition to this global collaboration, is making sure that we have a transition from the acute phase toward a more programmatic approach. We cannot just drop everything at once. We need to continue surveillance. We need to continue to take care of patients. We need to continue to have testing and continue also to make sure that the most vulnerable population and groups on Earth are still protected. And so I think these are really the two challenges we have currently. Thank you.
Thank you. Yeah, I mean, Sylvie answered this beautifully. I mean, I think these are the key things that we need to do. We're in a challenging phase right now. No one really wants to talk about COVID anymore. We all want to be done with this, and every single one of you listening in, all of us on the panel want it to be over as well. But as you know, we have a responsibility to really describe the risk and describe what needs to be done. And it does require a global effort to do that. We're much better off than we were 3 years ago. But there's still more work to do. And what we want, we need to change this narrative that we are dealing with, we are responding to COVID-19, and then we'll finish with that, and then we'll deal with the next one. Actually, everything that we are doing in terms of dealing with COVID-19, strengthening systems, building from systems that existed before, strengthening labs, strengthening surveillance, strengthening clinical management, working with communities, building trust, that's preparedness for the next one. Responding to COVID is pandemic preparedness for the future. So it's an investment, and it can't be lifted all at once. So what we need to do, as Sylvie pointed out, it's this transition phase. I really dislike this word. I really hate saying the word itself, but to kind of get through this messy phase where there still is uncertainty till we get to the point where COVID is one of the diseases that we manage. We're just not there yet. So we need a little bit of time, and countries are in different situations. So we will not stop until the emergency ends everywhere. And we're on the right track. We just have to remain vigilant. We cannot become complacent. Too many people are dying unnecessarily. This is what we're focused on because we can prevent those from happening. Some things we can predict and plan for. And as Anurag pointed out, there's these scenarios that we work through, but there's a lot of uncertainty. We just have to be ready and to be agile. Individuals out there don't have to worry about this on a day-to-day basis. Know what your risk is and the risk to your loved ones, but we need governments to be focused on this and really strengthening those systems for COVID and for everything else. So lots more work to do, but we are optimistic that we will end the emergency of COVID this year.
So maybe I'll go next, and this is just to add that I fully agree with what has been said by Maria and Sylvie. I think the main point I'd like to stress is that we have seen the emergence of Omicron in November 2021, and ever since this variant of concern has dominated the scenario, the variant scenario. So this is a good sign, of course, but I fully agree with what Sylvie said, that it's still virus evolution cannot be predicted, and so we need to remain vigilant in that. But of course, the situation is improving, and we are certainly in a much better position than we were 3 years ago. So I think we just it's just important to remain vigilant and then keep up with the surveillance and sequencing to make sure that we can track the evolution of the virus.
Very briefly, my prediction for the coming time: the virus will still be there, the need for vaccines will still be there. My hope for the coming time: the virus will not change by much from what Omicron is, but the vaccines will change a lot and become more effective against stopping infection, because that's the way this pandemic will end, like many previous pandemics. Thank you.
That's a great closure. Thank you. And if I can just put here the last and maybe key sentence: we will not stop until everyone is safe and protected. I completely agree. And we are all here, to support the country, to support the people, and make sure that, well, somehow we get to the end of this marathon, because we are already entering the fourth year. We entered the fourth year, correct, of the pandemic. So, but we will get there. Thank you so much, everyone. I really want to thank to Dr. Sylvie, to Dr. Maria, to Dr. Lorenzo, to Dr. Anurag, and all of you that were online. Thank you so much. As always, we will be seeing you soon on the next EPI-WIN webinar, and please stay tuned. Do go to our website. You will have the recording of this session as well as the presentations. So thank you again, and looking forward to seeing you in the next edition on our EPI-WIN webinar. Thank you. Goodbye. And special thanks to Dr. Maria, who is joining us from Brazil. Thank you. Thank you. Yeah, I mean, we are